So welcome everybody. Happy World TB Day. My name is Chris Lamb, and I'm the president and CEO of the BC Lung Association. This webinar today is a joint collaboration between ourselves and the BC Centre for Disease Control. The first thing I want to do is acknowledge that our BC Lung Association office and the basement that I'm coming to you from is on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. On this day, 139 years ago, seems like a very, very long time, Dr. Robert Koch discovered the bacterium that causes TB, really setting us on that pathway towards diagnosis and treatment. Today on this webinar, the theme is "The Clock is Ticking." It's intended to signal to world leaders that time is running out on the commitment that we have made as a global community to end TB. Particularly against the harsh backdrop pandemic. I do want to point out as we get started here that across Western Canada, we have a number of landmarks that are going to be lit up red in honor of World TB Day. There's too many to list, but I'll highlight a few. BC Place, the Vancouver Convention Centre, the Legislature in Victoria, the Vernon and District Performing Arts Centre, the Calgary Tower, and of course, the High Level Bridge in Edmonton, all will be glowing red today in honor of World TB Day. Today, we're honored to have this webinar led by two world-class experts in the field. That's Dr. Victoria Koch and Dr. James Johnston. Dr. Tori Koch is the medical head at the BC CDC, and Dr. James Johnston is the head of respiratory medicine at VGH. We have a lot to get through today. I think today is going to be a day of learning, a day for us to really push the envelope in terms of what TB means in our community. So I'd like to turn it over to Dr. Victoria Koch to lead us through a very important day.
Thanks very much, Chris. I think I would add to that today will be a day of reflection as well for many of us. My job today is to moderate the session, make sure that we keep to time, go through some questions and moderate the chat. But more importantly, my role today is to introduce the speaker, Jay, but also was to introduce Ed Walkus to the group. I think what I'd like to do right now, before I pass on the microphone, as it were, to Jennifer Sammartino to say a few words, I'd like for all of us just to take a moment of silence to honor the man that was Ed Walkus. Thanks very much for that very respectful minute of silence. Jennifer, can I pass it over to you?
Thank you. My name is Jennifer Sammartino, and I am with the First Nations Health Authority TB program. It is with a very heavy heart that I share the news of the passing of Edward Walkus from the Gwasile-Naquadah First Nation. I had the privilege of working alongside Ed for many years. Ed was passionate, courageous, full of life and light, and he made everyone he came in touch with smile and feel important. He was a 2-time TB survivor. That is how strong he was. He was an advocate for all those with TB or whose lives have been touched by TB. He had dreams of a TB walkathon and also of having headstones placed for all those who passed at Kokalitsa. Edward was a beautiful light in this world, and he will be greatly missed. For all of us who have had the opportunity to hear his story and his words, we will hold them in our hearts forever.
Thanks very much, Jen. That was lovely. I know I can speak for many to say that Ed was very excited about today, as he is about any time speaking about tuberculosis and sharing his story. He would have absolutely loved to have been here, and I will dearly miss him. Thanks. Okay, moving on. I would like to introduce a colleague of mine, Dr. James Johnston, otherwise known as Jay, who works with me at the BC CDC. He's the research evaluation lead at the provincial TB program. And as Chris outlined, is the division head for respiratory medicine at Vancouver General Hospital. And he is my right arm that allows me to have a bit of a break from TB and takes care of everything when I'm not there. So he's a much treasured colleague. Jay is going to take us through a talk for our World TB Day Forum. You will notice that there is a chat box. And so I would welcome you all to please put your questions or comments in the chat. And when Jay is finished with his talk, I'll endeavor to make sure that I get to the very top of the list and that we can try to get through all of the questions and comments before the end of our session. So without further ado, let's pass the field over to Jay, and you can share your slides and check your mic.
Hi, everyone. Thanks, everyone. Obviously, a tragic situation, and I just wanted to say that my talk will actually be talking directly to this issue. Coincidentally, but I just want to recognize that this is a bit of a difficult talk to get through given the situation. So, all right. Can you see my screen? Okay. I cannot figure out how to move to a separate, to the first terminal, so I'll be facing off in the distance while talking about this, but today I'm going to be talking about life after TB. And specifically the increase in what we term in the medical community morbidity and mortality in people who survive TB. The group that is on today is my understanding is that it's quite mixed, is TB advocates, TB survivors, scientists, TB care providers, from all over the world. And so what I'm going to try and do is create a balance here where I talk a little bit that addresses every group. And I apologize if I don't exactly speak to what you want to hear, but I am trying to address everybody. And feel free to put questions in the chat box. There will be some scientific jargon and some scientific figures here, but I will try and get through and explain those things. And obviously we have some time afterwards. I'm planning on talking for approximately 30 to 35 minutes and leaving at least 15 to 20 minutes for discussion. So we'll get started. So in terms of my funding, I have no commercial conflicts of interest. I do receive funding from Canadian Institutes for Health Research, our national research funding agency, TB Vets, which is a local charity, Michael Smith Foundation, which is a BC-based health organization for funding, and the U.S. Department of Health and Human Services. I have a salary grant for the Michael Smith Foundation, but I don't receive any commercial funding. So I'd like to acknowledge first and foremost the patient partners and advocates, and specifically on this day in particular that obviously hits home. without patient partisan advocates, I actually don't think that this talk would be given, because patient partisan advocates have really highlighted this issue as a major issue of life after TB. I'd also like to highlight the BC CDC TB services team, nurses, pharmacists, admin leads, operation leads, my physician colleagues. Without this, I wouldn't be able to do this research and wouldn't be able to do this discussion. And I'd also like to highlight that a lot of this work is actually coming from Andrew Basham and Camilla Romanowski, who are two PhD students working with me. And I'll be showing a lot of their work. And so I would like to recognize that they did the lion's share of the research and really many of the ideas that come through today. And my colleague, Tori Koch, who's on the call today, Isan Kareem, David Patrick, and Shoju, who have helped this research go forward. So I think most of the people know here, but just for those who aren't aware, TB until 2019 was the top infectious disease killer. 1.4 million people died of TB. This was before they initiated TB therapy or during TB therapy. And I think that's a really important caveat. Before or during TB therapy, this was the top infectious disease killer. This does not include people who died after TB therapy. 1.4 million people had recorded COVID deaths by November 2020, to give you some comparison. So COVID passed TB technically in November 2020, just to give you an idea of, this is happening every year with tuberculosis. And TB was declared a global health emergency in 1993. So it's still happening. It shouldn't be happening, but it is. And we need to pay more attention to TB. Things have improved. We have improved detection in particular. You can see here that notification of new and relapse cases have gone up, and that similarly, the number of TB cases have gone down, meaning getting people into treatment is really important to get the outcomes. And also the outcomes are really important. What we measure are really important. And you can see on the next slide that 3 million people were undiagnosed or not reported. And so that is really unfortunate. This is largely in regions that don't have the resources to diagnose and treat. That is particularly poignant this year, where things like GeneXpert have been used for COVID detection rather than TB detection, and diagnosis rates have plummeted in some regions. This is an infectious disease. This is not going to go away by not diagnosing it. And so we need to ramp up diagnosis. We need to ramp up treatment. That is clear. It's also important how we measure these things. So the World Health Organization is very good at establishing measurements and trying to hold people to task for that. What I would argue, though, is that these measures are now inadequate when it comes to tuberculosis. So right now, the TB outcomes that are reported to WHO are ramping up. We can see that the number of cases is ramping up, the number of people who have actually TB outcomes is ramping up. But I think we need to start considering, what are those outcomes and what are those metrics and how are we holding ourselves to account? We can see that cured and treatment complete is the top outcome. Cured is synonymous with treatment complete in the literature, but I think that we have to consider whether or not this is truly a cured disease. Death, failure, loss to follow-up, these are treatment outcomes that are measured. The only post-treatment outcome that we measure right now is relapse, which is essentially somebody who finishes treatment, goes and lives their lives, and then gets TB again. And that happens very frequently, as we've already heard. But it's the only post-treatment outcome that we think of. We don't consider all of the impacts that TB has on that person's life, which is not even accounted for when we talk about these metrics in terms of the number of people that TB has killed. And so one of the simple questions that many people in the last 5 years, egged on by advocates and TB patients, is what happens to people after they finish TB therapy? This has been largely unrecognized in the literature till about 5 years ago, maybe 10 years ago. But what does happen to people after they finish TB therapy? And so the first question I guess I would have is, and I did have, was, well, what is the scope of this problem? And so there's been a very timely publication produced by a group led by Peter Dodd in the UK, looking at the number of TB survivors, modeling this in the year 2020. And for the number of TB survivors, they estimate since diagnosis in 1980, so people who are diagnosed prior to that is not including this number, that there are 155 million people living worldwide that have been diagnosed with TB and are alive and were alive in 2020. That is a lot of people. And to put that in perspective, based on my very brief calculations, that is 1 in 50 people globally have had TB and are alive. And so I think we need to know a lot about what's happened to this group, and we really don't know at this point. And I'll describe the literature that can help gain some understanding, but we have a long way to go to truly understanding what happens to people in their life after TB. So the first thing I would go to is what happens to people after TB in terms of their mortality? Do people die at a higher rate with tuberculosis after they've completed therapy for tuberculosis? This is supposedly a curative disease. They're cured after they complete therapy and go on. Do people with TB die at the same rate as the rest of the population, or do they die at a different rate? And that would be informative to let us know that how people are living post-TB. So this was what's called a systematic review and meta-analysis performed by Camilla Romanowski, who's working with us. What she did was take all of the publications that looked at people who had tuberculosis, and they compared their mortality, meaning how frequently they died after tuberculosis therapy, and compared them to an age and sex matched population. Okay. What she found, and what this is this is all the different studies. For those who are not familiar with the way meta-analysis works, this is all the different studies that were published, and this is their results. Anything to the right of this line means that the tuberculosis group had a higher rate of mortality. And so what she found was that TB survivors have 3 times the rate of death compared with matched controls. So triple the rate. That is extremely high. She also found that when you looked across different subgroups, this didn't change. If you looked in a high-income country, so if you looked in Canada, for example, the rate was 3 times. If you looked in a lower income country or low resource country, the rate was essentially 3 times. If you looked in older people, younger people, it did not change. So this is across the board. People are at risk of death post-TB. Well, what do people die from post-TB? Well, cardiovascular disease, cancer, respiratory disease, and, trauma. We found that people have recurrence of TB, have progression of potentially HIV. And so these are the diseases, and I want to unpack actually pretty much each of these because I think it's important. What is notable is that it's not one thing that is causing this. And there's not what I would call extraordinary things, surprising things. These are things that the general population get. The general population gets cancer, cardiovascular disease, respiratory disease, and so do TB patients. If you look at the general population, you can see that the same causes of death are there: heart disease, cancer, unintentional injuries, respiratory disease. So these are the same causes of death in the general population as happened to the TB population, except TB survivors it's happening at essentially triple the rate. Is this happening in British Columbia? Because we are here in British Columbia. Yes. This is an analysis performed by Andrew Basham, who's working with us doing his PhD as well. And he found similar findings that, again, cardiovascular, respiratory disease, cancers, injuries and poisonings, which includes trauma, obviously, are increased in this group. And so, again, the same causes of death that happen in the general population are happening in people who are surviving TB, but at a higher rate. I think the hopeful thing that I want to recognize from Andrew's analysis is that we have time to make a difference, okay? So what this is the number of people who are surviving post-TB compared to random or matched controls, I should say. And as the line goes down, that means a higher proportion of people are dying, okay? Over time, over 10 years, you can see that this is happening. This is not happening right away. So people aren't dying the day after they finish TB therapy. They're happening, it is happening for years and years and years down the road, which means we have time to intervene. We have time to look at the risk factors. We have time to actually address these hopefully preventable causes of death. And so I think I don't like to give only bad news. I think this is actually a very hopeful statement that people are dying, but we have time to intervene if we can just do so early on. So I want to unpack each of these things. So we know that people are dying of respiratory disease. So what is the situation with respiratory disease post-TB? So after TB, you can be left with a number of problems. Many people, actually, when they complete TB therapy, they truly are cured. They truly have no respiratory disease. They truly have no respiratory problems. So I don't want to say this is happening to everybody. And I don't want people to walk away with that message thinking that they in particular are always at risk of this. But some people who have severe disease are left with multiple different respiratory problems. And that would include fibrosis, meaning scarring of the lung, which has caused shrinking of the lung, airway disease, or COPD, which is synonymous to some people with a type of similar to emphysema. Pleural thickening, pleural disease, which can cause shrinking of the lung. All of these problems exist. And so again, to what extent do they exist? Well, similar to the Romanowski paper, as I mentioned before, a meta-analysis was performed. So again, each of these was an individual study looking at outcomes of people who had TB and looking afterwards to see if they developed bronchiectasis or COPD. And again, what this found was that TB survivors had about triple the rate of bronchiectasis and COPD when they compared to the general population. So about triple the rate, kind of a theme here. What about British Columbia? Again, this is analysis that Andrew had performed, Andrew Basham, showing that 43%, that is an incredibly high number, 43% of people developed airway disease post-TB compared to about 11% in the general population. And this didn't happen immediately. This happened over time, over 5, 10, 15 years. Again, we have time to intervene on this. People are developing disease, but we have time to address it, screen it, and potentially treat it, depending on what it is. So in respiratory disease, we know that there's a high proportion of people who develop obstructive disease, bronchiectasis, restrictive disease. Is this because of common risk factors, meaning people who smoke get higher risk of TB, and that they're also at high risk of obstructive disease? Potentially, but it's not the only explanation, because we know in some studies, such as the BOLD study, amongst others, that even smoking alone did not, after you control for that, after you took that under consideration in your calculations, people still had more obstructive disease than expected. So it's not from smoking alone, it's probably not from pollution alone, although that's harder to measure. There's something to do with TB in and of itself that can lead to this disease. So cardiovascular disease, another major cause of morbidity and mortality, both globally and in TB patients. So there appears to be an association between TB and cardiovascular disease. Cardiovascular disease is very broad. There's multiple things that we can call cardiovascular disease. What I mean by this is myocardial infarction or heart attack, unstable angina, which is leading to a heart attack, death from heart disease, and a stroke. So when you talk about these MACE, what Andrew wanted to do was look at, do people with TB have higher incidence of MACE, these very common cardiovascular conditions, compared to the general population? And again, this is a meta-analysis. You can see a theme here that on multiple studies, it was shown again that people with TB and TB survivors have higher rates of cardiovascular conditions compared with the general population. So is this from common cardiovascular risk factors such as smoking, which is a risk factor for TB and cardiovascular disease, same as diabetes, older age, socioeconomic status? Perhaps, but it's not alone, because after controlling for these things can still exist. And also there's been some very good studies by Moises Human in Cincinnati, who shows that in studies in Uganda and Peru, he showed that actually people who are diagnosed with latent TB have a higher incidence of cardiovascular disease. So it may have something to do with the TB infection in and of itself and not common risk factors. How about cancer? Some cancers are established TB risk factors. Lung cancer, sarcomas, gastrointestinal cancers, head and neck cancers have all been associated with developing TB. But cancer also is higher in post-TB therapy. This is not as well studied as respiratory disease or as cardiovascular disease, but certainly we can see that in this study from Denmark, over time, years after tuberculosis treatment, above the line means higher risk of cancer compared to the general population. And year after year after year in Denmark, TB survivors had a higher risk of cancer compared with the general population. Which cancers was this? Well, it seems to be largely driven by lung cancer, meaning lung cancer happens more frequently in TB patients in the many years post-treatment compared to the general population. So certainly smoking could definitely explain some of the risk, and potentially people could have been diagnosed with lung cancer while diagnosed with TB and it wasn't picked up. Certainly chronic inflammation could play a role, but to be honest, I think we need to research this more. But again, like cardiovascular disease and respiratory disease, knowing the cause is important, but I think also at the same time, we need to figure out how to address this regardless of the cause, because these people are at higher risk. We need to look for that. Post-TB mental health. So we all know that mental health is a major issue with disease. I think we're all experiencing challenges to mental health over the past year with COVID. You can imagine that the isolation that a person has with TB can have impacts on mental health, as many of us have experienced in the last year. This is not as well studied for post-TB, but what we do know is that close to half of people experiencing or with TB experience depression during TB therapy. Close to half, okay? And there is some evidence emerging that post-TB depression is more frequent in TB patients. So people who, have finished TB therapy are at higher risk of depression after TB than prior to TB. Although a lot of that right now is still unpublished evidence. And, so I can't go into it much further than that. But it appears that potentially mechanisms of, hospitalization or isolation may be playing a role in worsening people's depression, or at least actually causing depression. And so this needs to be studied more. And I think something that is probably obvious to many TB care providers and TB patients is that there are massive, massive financial, however you want to call it, impacts, socioeconomic impacts on TB patients. TB causes isolation, can cause stigma, can cause sickness, which prevents you from working. And these have massive financial impacts. And TB programs globally don't really have great mechanisms to support people because oftentimes they're cash strapped themselves. So this is a good example of a study on Malawi. There's very limited data post-TB, but a cohort study in Malawi did explicitly examine this and looked at people pre-TB and then checked them out a year post-TB to say, okay, what happened between the pre-TB situation where you were to 1 year after you've prevented TB therapy? Did you go back to normal financially? Well, it turns out no. People who were in paid work decreased from 72% to 63%. 9% of people basically stopped paid work. That is a huge number of people, 9%, when you think about unemployment terms. 11% moved from employed to self-employed. Although they're technically not unemployed, we know that a lot of people who are categorized as self-employed have a significant drop in their social safety net, a significant drop in their income, and may actually be unemployed at a practical level. And I think most importantly, poverty in this group increased from 41.6% to 57%. That's like a 15% increase in poverty in people pre-TB to 1 year post-TB. That is hugely impactful on so many aspects of that person's life, including their disease status, but also the rest of their family, how their family is going to eat. This is, catastrophic to people. So in summary, TB survivors die of similar diseases as the general population, but at a much higher rate. And I think we need to recognize that we aren't looking for zebras. We're not looking for these odd causes of death in people. People with TB are just at higher risk for many, many different reasons. And so TB screening programs need to recognize that. People develop respiratory disease at a higher rate. People develop cardiovascular disease at a higher rate. People are likely diagnosed with cancer at a higher rate, although that's not definitive. People likely suffer from mood disorders, and people suffer financial losses. And we need to recognize that when we're in TB programs, when we're engaging people, and we need to figure out, as the TB program, how can we provide better screening, treatment, and care to people to ensure that this does not happen anymore. You know, we in TB frame TB as a curable disease, yet after treatment, people are obviously embedded in this network where they're still at higher risk of other diseases. And we need to figure out how to help extract people from that network of disease. So when we bring this up with colleagues in the TB community, oftentimes outside the TB community, people have a lot of excuses. And some of these common excuses that I've heard, and I think many of us here have heard, is that, well, we don't know what the actual cause is. You know, association isn't causation. It might just be from the fact that they're smoking. I don't care. It's still a problem. You know, whether it's the causal factor or not is not important. The fact that people are at higher risk is important in my mind. We need to untangle the cause eventually, but we can still do things now. People also say this highlights the importance of prevention of TB. That is true. I think there's no question that preventative treatment for TB is okay, but that's not an excuse to ignore the problem after that person does come down with TB. People say the damage is done. I'm not sure how we can help. Well, I think we can, and I'll propose a couple ways how. And people often say this is a primary care issue, and that's true. And maybe we need to re-engage primary care, take TB out of the silo, make TB or TB programs more primary care oriented. I'm not sure. I think that depends on the place, the resources, and the people involved. I'd just like to highlight that this is actually ingrained in our national guidelines. Canadian TB standards, which are being renewed now and will be addressing this at some level, state that follow-up after treatment, as a general rule, patients who have completed treatment are judged to be cured and do not need follow-up after treatment. You know, that is a very, very definitive statement. And I think we can see that from the past 20 minutes of my discussion, that that is actually not a true statement. And we need to really readdress this, reassess what are we doing in terms of care outside of actually treating people for tuberculosis, and what metrics are we using to actually measure that. So my response to this is, I think we can screen, I think we can risk stratify people for cardiovascular disease, we can screen people for cancer, we can screen people for mood disorders, we can screen people for substance use disorders. All of these things can be screened for during TB therapy. We can enroll people in smoking cessation programs. We can enroll people and advocate for them in drug and alcohol misuse programs. And we can do something to advocate for TB patients to limit the financial impacts of TB disease. Whether that is direct cash transfers, whether that is policy changes within your government to ensure that people are protected if they have TB. I think we can do a lot to advocate for people. But we need to do these things, because if we are framing TB as a curable disease, we need to address all the things that are increasing the morbidity, what we would call, and mortality in people with TB. And this is a quote I really like from Salman Khashoggi from Harvard Medical School and Partners in Health. This is something that guides me a lot, and I just like to share it with people. So a lot of people have limited vision when it comes to thinking about what we can do for TB. That vision doesn't seem to be limited for HIV, building airports, or putting people in outer space. It's only for TB. For some reason, we limit ourselves, or the communities around us are limited, and we need to advocate harder for TB patients and broaden the scope of what we mean by TB care. TB care has been very siloed with very narrow metrics determined largely by these WHO reports. And I think they are in some ways doing a disservice to TB patients in the sense that we are not providing that holistic care that people need. We often talk about addressing the social determinants of health in TB care. And I think this is a really good way to do so, is to say, we need to, elevate our care to improve the financial and holistic health of TB patients. And in doing so, we can address many of those socioeconomic determinants, hopefully. For those who are interested, this is a TB infographic that Camilla Romanowski had created and that we have hanging in our clinic. If people want to contact me, I'm happy to share that PDF. I apologize, I forgot to actually put the link on here. This can help get it started, help start the conversation. This is not the answer, but this helps bring awareness in your clinic to the problems that patients have. And I would strongly advocate that if you work or link to a TB clinic, that you have some discussions within your clinics, within your programs, to see how you can raise awareness about post-TB health outcomes and potentially start addressing some of these issues, whether through research or through direct treatment or linkage to primary care, whatever you can do. I'd like to thank you. This is a picture of Ed. Would have liked to have been here. Thanks very much.
Thanks very much, Jay. And that is the tie that I will always remember that Ed loved to wear. Brilliant, brilliant blue. Beautiful art on it. What a great man. Thank you, Jay. So I see I've been watching the numbers climb up mainly. We have 72 participants, which is lovely. And I would like to encourage you all to put your questions in the chat. And I will keep track of that the best I can. We have about 20 minutes. I wanted to just ask, before we get into the questions, we could put the link to Camilla's infographic into the chat. I'm sure someone has that. We can pop that in there. Jessica Harper already did. She, well done, thank you. I just wanted to, before we go into the questions, I just wanted to acknowledge, oh, go ahead.
Sorry, I think that was me on mute.
Okay, that's okay. I just wanted to acknowledge that we have a TB survivor, Willie, who has been writing in the chat. Thank you very much, Willie, and thank you for the link that you put through. That's great. And for those of you, I won't read out the entire comment there because those of us can go through that. But Willie's really described some of the challenges that he's had with TB and treatment and the difficulties with all of the after effects of not just of treatment, but of follow-up post, which really, gives us a true first-person account of, I think, some of the information, Jay, that you were sharing. Just as we, and also so as I said, Jessica has put in the link to the infographic, so that's great. And Teresa Rugg has also put a link to a global TB support group on Facebook that's available for folks, and that's in the chat as well. So Jay, maybe I'll just start off with a question, and it, actually reading the post there from Willie. I have a couple of questions, but put this up to the front, and it really is around messaging of this type of information to TB patients and TB survivors. You had said in your talk that you didn't want to sort of scare people that this was going to happen to them, or that every one of these things was going to happen to every single person. And I'm just wondering how we balance that and what your thoughts are around, balancing out the messaging to try and shift away from fear-based messaging into more sort of action-oriented and empowerment messaging. It's a difficult subject, and I'm interested in what you think about that.
Yeah. I think, you know, for those TB survivors who are on the line, I think one thing important to recognize is that these risks are, you know, relatively, they are, you know, high relatively to the general population, but on a day-to-day basis are still low. And I think what we need to do, I don't have the answer, so to be clear, and I think we, you know, to get the answer, we need to hear from TB patients in particular, and we need to hear from many TB patients, because many TB patients will have different ideas, I'm sure, on how to message that appropriately. So I want to say that caveat that I don't have the answer, but my personal thought is, if I were a patient, I would want to know that people are doing everything they can to improve my disease, and that includes improving all the diseases around that. And so I think we can do a better job describing health promotion. We can do a better job describing, you know, screening we can offer, treatment we can offer if we find diseases. Right now, we're still in the, unfortunately, we're still in the descriptive phase, meaning we're still in the, what is the problem? Before we can solve the problem, we need to identify and measure it, right? And so that's what I described today. But I think once we are getting into the intervention phase, I think the first thing that TB clinics, TB scientists, TB advocates, TB survivors need to do is talk to current existing TB patients and say, how do you want to message this? How should we message this in a positive light through health promotion, I assume? Is that how people would want that? Because I know when I go to my doctor, and if I were to talk about high blood pressure, for example, I don't want them to necessarily catastrophize the high blood pressure, but I want them to say, you potentially have high blood pressure, and if I find it, I can treat it. And so I think if we're going to, you know, talk about post-TB care, we need to talk about doing something about it, not just describing it. And I think that's still where we are right now. So I don't know if that's a long ramble. I don't know if that answers anything.
No, but I think it nicely outlines where, you know, where we're at. And again, when you think about your comment of what lies within the Canadian TB standards, right, which was published a while ago, but not all that long ago, that, you know, it's a shifting field, and it's sort of important to recognize that we all, you know, we do have to describe the issue before we can actually make meaningful suggestions and comments about how we actually can address it. So we've got a couple of questions here from Jessica Harper. Thank you, Jessica. Jay, they're in the Q&A, just if you wanted to open them up so that you can actually see them. And they're excellent questions, a number of them. The first is, and I'll read them to you so you can percolate in your thoughts. The first is, do we have a way of referring clients to primary care post-treatment in TB? The next is around collaborations with BC Cancer or national TB and cancer organizations, and I know that you'll have an answer for that. And then the third question is for Jennifer Sammartino, so I'll just hold off on that and let Jay, you go for those first two, and then we'll come back and circle back to the last question that Jessica has there.
So Jessica, thanks for the questions. I think I'll answer that in two ways. I think, first of all, do we have a way to refer clients to primary care post-TB treatment? We do. We have, I mean, normal referral pathways, assuming that that person has a primary care provider. And so I think that, I don't know the exact same, but that which is not measured is not done. I think one of the things we need to do is actually impose a metric on ourselves, an outcome where we measure what proportion of patients are linked to primary care within a certain amount of time, right? And so if we impose that on that metric on ourselves and we start measuring it, then it's going to improve. And so I think we can do that very easily by saying, okay, let's just impose that as a metric that you need to be linked to primary care after TB therapy within 3 months. And what proportion of people actually had that done? How we measure it, I don't know yet, but having a metric like that would be actually quite useful to know that we are getting it done. For those who don't have a primary care provider, we'd have to find them one. then that may be a responsibility that we have through migrant health clinics, through First Nation Health Authority, through all different mechanisms. I think we can work on that. But I think the first thing we need to do is actually start measuring it. I know I'm talking very much like a scientist. The second one is, do we have any collaboration? We don't. I mean, we have collaborations in terms of data. I don't think we're at a situation yet where we should be screening for all cancers because we don't know. But I think for lung cancer, we can do a better job of screening lung cancer patients for TB and potentially looking at TB and lung cancer, or looking at lung cancer in TB patients. How to do the latter, I don't know yet. But I certainly think we can do a better job screening lung cancer patients for TB. Yeah, that's what I have to say.
Thanks, Jay. The third question I'll read out to you, but just before I do that, I just recognize that Chris reminded me and all of us just to forward a big thank you to Jessica for her role in supporting the red lighting of landmarks across certainly across BC and into Western Canada. There are landmarks being lit across the Lower Mainland in Victoria, Vernon, and in the Okanagan, Calgary, Edmonton. So very much thanks to Jess for that. The third question there is to Jennifer Sammartino, and the question is Jennifer able to speak to what they do with FNHA TB services and the support they give during TB treatment to help with financial challenges?
Thank you for the question, Jessica. I was thinking about this, and when I had the honor of working alongside Isa Wolf, she always shared with us that people on their TB journey previously were very alone. And it's our job to surround them with everything they need to have the most success. They're doing their piece at taking the medications to heal, and we need to ensure that our clients on this TB journey, they are not alone, that they're surrounded by a team. And we are able to look at each client individually to see what is this person, what do they identify as a need? And if it is a financial need, what can our program do to support that person on their TB journey? So it's looking from, is transportation an issue? So really making sure that clients, have the ability to get to appointments. If finances are an issue, what are ways that we can ensure that this client does have the finances to be able to support during this TB journey? So just really individualizing each plan, and the care doesn't end when somebody stops taking their TB meds. We make sure that we are there to follow them years beyond. And I really want to give credit to our program having the ability to do this, and Isa Wolf, making sure that that was vital in our program. So thank you.
Thanks for that, Jennifer. So the next question in the Q&A is from Claire, and the question is, do these possible sequelae relate only to individuals with active disease versus latent disease or latent TB infection?
Sure, you don't want to take that one, Tori? That is a tough question. Thanks, Claire. Nobody really knows, and this ultimately gets down to this causation issue. This cardiovascular disease issue is interesting in that way, in the sense that there is a little bit of evidence to show that maybe people with latent TB infection have higher cardiovascular risk than people who don't have latent TB infection. But is that because the people with latent TB infection somehow are different than people without latent TB infection? They're embedded in higher risk social networks or different lifestyles. So nobody knows, to be frank. Cardiovascular disease is the most that's been explored in this, and there's only been 1 or 2 studies really from one investigator group. In terms of respiratory disease, depression, substance abuse, mood disorders, cancers that has not really been looked at because it's been barely looked at with active disease.
Thanks, Jay. You did a better job than I would have done answering that question. I think a little bit on that line, I see Teresa's got a question. I'll get to that in just one second. I wanted to sort of just, around that, the concept of active disease and latent TB infection, and how, we sort of know that the dichotomy is sort of broken, right? There's a continuum there. One of the things that actually I didn't appreciate, I've seen your data before, and one of the things that really struck me was that concept that the increase in mortality is really quite sort of fixed or stable over many, many, many years, right? So you're showing data 35 years out from a TB diagnosis where the mortality is still 2 to 3 times overall mortality. And I wonder, when we think about, oftentimes when we see adult TB and we see quite aggressive and destructive forms of pulmonary disease, whether, what your thoughts are around, pediatric TB and how, whether or not we actually need to be even more aggressive with pediatric clients who clearly are going to have longer lives and a greater overall cumulative risk, and whether there's any work done on that from a descriptive perspective.
Yeah, it's a really good point. And to my knowledge, at least in BC, I don't know if it's being examined, but it would be a really useful thing to look at, to see if we can intervene earlier, or if we need to intervene earlier, obviously. Yeah, but I don't know of any, but that may just reflect my ignorance of the literature.
Okay, Teresa has a question here for you in the Q&A, and I'll read it out. So much like long haulers who have had COVID-19, you've clearly highlighted the importance of TB care post-treatment. Are there current TB programs that extend their treatment period beyond the medicine period, so assistance in the year following TB treatment?
Thanks, Teresa. Good to see you via text. Well, there are there aren't comprehensive programs, at least that I know of in North America, looking at post-TB. I know that there is a post-TB clinic in South Africa, I believe in Durban. So there are post-TB clinics starting to emerge, and there's post-TB research, which inevitably will lead to post-TB clinics. But to my knowledge, in North America, there's no comprehensive post-TB clinic. Here in British Columbia, we don't actually say goodbye to patients at the end of the therapy. We have them come back 3 months, 6 months, 12 months, depending on the scenario, to make sure that they're doing okay. To be frank, that has traditionally been more to look for evidence of relapse, not for screening for smoking cessation programs or substance use. It hasn't been a comprehensive primary care program, but there are some emerging, especially in higher incidence communities. I think in high resource / low incidence communities, there's an opportunity here. I mean, I actually was intimately involved in developing our post-COVID clinic, and how quickly that was set up. Yet, as a TB physician, I haven't set up a similar program for TB patients. I'm sort of, reflecting on that, and there really is a disparity there between the post-COVID and post-TB. And especially since post-TB, there's so few people, you think we could do this better. But the real question is how, and that we don't know. And it goes back to, in my mind, to that Salman Khashoggi quote, where every time we bring up these things with COVID, everyone's like, here's some money, go, go, go. But every time we bring it up with TB, it's, well, is that cost effective? Well, what is the difference you're really going to make in these people? And there seems to be this block with TB where when we start applying for funding and looking for funding, and I'm not saying that happens in BC in particular, we actually have a very responsive health authority here, but just broadly speaking, it seems like we have to yell extra loud in TB to get the same resources. But we just need to do that, unfortunately, and it would really help to get more advocacy to help us do that.
So Jay, that answer was a perfect segue to, I'm going to draw folks' attention to the chat where Jess has challenged us all to take action tonight with a link to the Results Canada website around World TB Day landmarks, and you can, I think all of you can have a look at what it says in the chat. Essentially, either taking a selfie or a photo or a video of yourself around some of the lit up landmarks, and if you don't, homemade signs, and tagging them to your respective MPs or people in positions wherever you've joined us from for today. So I'm just looking at the time. We're at 10:56. I don't see any other questions in the Q&A, and I'm just cruising through the chat. I thought maybe in the absence of any other questions, I wanted to maybe ask, maybe I'll tie things up by sort of a question around responsibility. And so I guess, and again, I'm not sure that there is an answer, but just interested in your comments around, when we're talking about life and care after a TB diagnosis and treatment, whose job is it? Whose responsibility is it to do that? And if we want to move away from or move towards more meaningful outcomes, so away from the concept of cure, right? That you have a negative culture at the end of your treatment, therefore you're cured and we're done. Where does that land? Where does the responsibility land? Where do you see that, Jay?
Yeah, I think the response is, it's the health system's responsibility, right? I'm targeting TB programs because this is an issue with TB patients, but as you know, many TB programs are cash strapped. So I think each TB program needs to reflect, and I think we, the BC CDC, need to reflect on what can we do realistically without hurting the care of existing TB patients. And if we can't do everything, can we make a way for primary care providers to provide that care? I feel like primary care providers are the natural group, but I feel like we need to be the advocates. We need to be the people who engage primary care and ensure that they can do that, or post-TB programs. But what I don't think is fair to TB programs is to say, here, now do this for the next 2 years with no extra funding. We need people higher ups in the Ministry of Health or whatever your state, local, provincial, national health system to take some responsibility for this and to start funding it. And the only way to do that is to be loud and noisy. But for now, I think we can, at least in BC, engage primary care providers and create our own metrics to make sure that we are engaging primary care providers. That's what I would say.
Okay, thanks, Jay. All right. Timing is wonderful today. I'm gonna wrap things up by saying thank you to a number of people. Certainly, Jay, for your talk, that was wonderful, and to the all the other panelists, Jennifer for stepping in and not only for answering the question but for the beautiful recognition of Edward. Thank you to the BC Lung Association, so Chris Lamb and Nen Biagtin and Matthew Wong for helping us in setting up this session. I certainly would like to thank the attendees for coming and for participating and for actually lending to a really robust conversation. I truly appreciate it. And I would just like to end the session today with just another thought around, sending exactly what Teresa said. Actually, that's beautiful, sending peace to Edward's family. So love and hugs to the TB family today. It's a tough day. Bye-bye.